Welcome to the Rural Emergency Medicine Podcast, the podcast for rural and community emergency providers. This is where your hosts, Carl Richards and Treve Henwood, explore the nuances of practicing in a small community emergency department. Welcome to another episode of Rural EM Podcast. Thank you for tuning in each month. This means a lot to both Treve and I. This is a great motivation knowing there are so many listeners out there. We really are trying to make a difference for the rural and community emergency medicine providers. We understand not a lot is for the small community, so this is why we are doing this, and this is why we are doing it for free. So please keep listening. Share this with your colleagues. The more people listen, the more we will be able to have other providers on the show and be able to provide even better content for you. So thank you. Today we have Dr. Craig Heacock. We're going to continue the discussion from last month. The discussion last month was too long, so we ended up splitting this into two different episodes. Today we're going to focus more on recognizing the psychotic patient in the emergency department. Psychosis is more of a disconnect from reality, not just severe agitation, and we often only focus on the agitated patient. But today is more on recognizing psychosis. Do you have anything to add, Treve?
The one thing I wanted to add is I think what led to this discussion was I had seen a couple patients in the ED and I was looking for some articles to read after a couple days later at work. And when I pulled up these ED articles on psychosis, basically every article talked about how much Haldol or equivalent we should be using and what combination and the efficacy and
B52.
Yeah, there you go. So that was when I started thinking, there's this whole subset of patients that have a definition of psychosis that I think really fly under the radar that we do not often recognize, or maybe we could do a better job with. So that's what brought the discussion up.
Well, all right, let's move on to the discussion now between Treve and Craig Heacock about recognizing psychosis in the emergency department. The session with our clinical psychiatrist, Dr. Craig Heacock.
I look at sort of the opposite side of the coin with psychosis, and that's those patients that come in under the radar that we talked about it earlier, and you mentioned that one of the first tip-offs for psychosis is paranoia. Mm-hmm. And we have a lot of those patients that I think come into the ED sort of fly under the radar that we don't really recognize, or we're not very good at diagnosing that underlying psychosis unless they're acutely agitated or, brought in a state of acute agitation. So talk to me about that.
Just recognizing psychosis.
Psychosis.
Yeah. So first of all, let's define. So psychosis is a general term that means losing touch with reality. And there are a number of symptoms that fall under psychosis. But again, in general, when we talk about people being psychotic or having psychotic symptoms, we talk about them losing touch with reality. And as you just mentioned, Treve, how that typically starts is with paranoia. What do I mean by that? So in the psychiatric sense, we mean paranoia, people starting to believe that there are all sorts of connections between disparate things in their lives that are very important. So it seems to be the roots of paranoia are an excess of dopamine intermittently shooting through the saliency circuit in your brain and intermittently telling you that things in your day-to-day life are deeply important and you better pay attention. That red car in the mirror, the way your boss is adjusting her eyeglasses. People get these overwhelming sense of pay attention, this is important. And through that, they begin to develop this sort of twisted network of belief that something very important is going on. It's not clear what it is. It seems scary, but it seems deeply important. And that's the underpinnings of paranoia, which, if we think of psychosis as a raging fire. Paranoia is the sparks. And when people are getting paranoid, are they psychotic? Well, they're starting to lose touch with reality because they're starting to think, why is it that I keep seeing red cars? Particularly, why do I see red cars at Safeway or some other bizarre observation? And they're making these links. And now you imagine, excuse me, this person sitting in the emergency room. And it could well be that they're having some intermittent shots of dopamine through their saliency circuit as they're waiting for you, as they're talking to you, as the nurse is working with them. And they are now connecting this to their deep web of suspicion and confusion about what's happening. So how are you going to get helpful information from someone who very well may think that you are now part of this growing, very scary, complicated web that's basically enveloping them?
And I think as ED physicians, these are the patients that I think we've all seen them, where you sit down, you sit at the bedside, you're kind, you aren't in a hurry, you're talking to them. You notice there's a few things that aren't maybe quite right, either the way they're dressed or maybe their eye contact or just things that are like little ticks that you might notice. But maybe I don't put them all together and I talk to the patient because they're in for something. For example, they've injured their ankle and you say, okay, you're limping. You've had this swelling for 3 days. You had a crush injury. Why don't we get an x-ray of this ankle just to be safe and make sure that, you don't have an avulsion fracture type thing. And very routine to you. You kind of write some of the other stuff off as, oh, maybe this is a personality quirk. And then you put the order in, you go on about your business, and then you are informed that the patient left because there's no way that you're going to take a picture of their leg and insert the tracking device secretly or influence their brain. And you think, what? How did this happen? Where did this person? And then it kind of clicks for you and you're like, oh, I did not recognize, or I didn't fully recognize where this patient was. And, I think that's what we're looking at in the ED. And those are the subtle ones where if we can identify them early, we can really make a difference. And, when we're trying to identify them early, if you see some of those patterns or you see some of those ticks or some of those things that aren't adding up, how do you approach that as far as initial history taking or questions?
Mm-hmm. So if I see, first of all, if I'm suspecting that there might be something deeper going on, if the pieces aren't adding up, if the story is not making sense, if I'm looking at them and thinking, okay, why are you wearing that beret at this early in the morning in this rural emergency room? Or why do you have so much glitter? Then I think I try to slow down and try to start putting the pieces together. And again, I think this relates back to something we talked in a prior podcast, the suicide podcast. I think one of the things that docs are terrible at is getting collateral information from family. And part of that's HIPAA, fears. Part of that's just being busy. I think some doctors think, okay, we need to respect the patient's privacy and autonomy at all costs. But the problem is there's going to be some percentage of these folks who the pieces aren't adding up, their eye contact's poor, their affect is restricted, they're just acting shut down and strange. Some percentage of these people have a very serious process going on. Now, most of them don't. I mean, there are plenty of people out there who are sort of quietly psychotic, who think, yeah, I have a tapeworm in my head and it's taking over my soul, but I can go to work, or I treat plenty of people that have very bizarre psychotic symptoms, but are sort of quiet or just not causing problems. Mm-hmm. And so even it's very possible that you could be alerted to, okay, something is not right with this person. They seem fearful, shut down, but it might not be a big deal, or it might be. So
talking to either loved ones, family members, close people in their lives, or trying to find those, so that you can get that background is invaluable.
Yeah. Much like with the suicide talk, we talked about just taking a few extra minutes and contacting family. I think if there's someone in your emergency room and you're thinking, okay, this is odd, this is bizarre, this feels off, this feels scary, my alarm systems are going off, something is up. I mean, a couple of things that I would do. Number one is try to contact some family. Hey, your brother's here, your husband's here in the emergency room, and I just wanted to check in. It seems like there might be something more going on than this broken ankle. Yeah, maybe the family member says, oh no, that's it. Or, oh, I'm so glad you called. Yes. Because in the backyard, my family member is doing something very bizarre in the back shed or whatever, or he started buying guns or started talking about needing to take revenge at work. The family collateral is the imaging of psychiatry. If you have any significant mental health concerns about somebody, if your danger meter's going off, or even just your weird or creeped out meter's going off, to take a few extra minutes and try to contact family. One, medical legally, it makes sense. But two, you might very well head off something very bad. And if you don't, no foul, no harm. I mean, sometimes you can get people, if it's early in psychosis, sometimes just doing simple kind of therapy, doctory things like, hey, you, you seem scared, or you seem like you are having a hard time, or you seem really uncomfortable here, or I'm worried about you, or sometimes you can engage people on that. If I've built up a little trust with people, even in initial eval, I'll use that technique that we learn in med school interviewing, which is the leading questions, so you don't ask people, how much do you drink? You ask them, hey, can you drink a 6-pack, or can you drink a 12-pack? Or you don't ask people, hey, do you do meth? You say, have you done meth this week, or has it been more distant? So sometimes with psychosis, I'll ask, again, if I feel like I've built up a little bit of trust, I'll say, yeah, how long has it been since you heard whispering or mumbling? Or, you seem sad, or I see you're taking some depression medicine. We find a lot that people with depression will experience scary things like mumbling or voices or scary commands. Just normalizing that. Again, I would say that's a bit of a fishing expedition. That's not necessarily going to hit pay dirt, but it's pretty impressive when you normalize and validate people like, oh yeah, this is a normal thing that we see. There's some percentage of people who will say, well, actually, yeah, I am experiencing these kind of scary thoughts or mumbling. And you're like, oh yeah, we see that. That's a thing. So giving people the opportunity to say yes to your admittedly leading questions. And again, trying to include family. And again, I think paying attention to your danger meter. I remember early in residency learning from a couple of different attendings that if you feel scared, get out. Don't wait. Don't think about it. Just leave. And the last hospital I worked in, I was the only male physician who wasn't physically assaulted. A number had some pretty serious attacks. And I think it's one, because I'm a fast runner, but two is I'm doing what I'd encourage all of you to do, which is if your gut tells you that something is up, go with that. That's you've been doing this pattern recognition in the emergency room for a long time. If you feel like something is not right, the tendency is to say, well, it probably is. I'm busy. We've got to move on. If you get that sense that is time to stop. Again, maybe do some exploratory questions, but at the very least, try to talk to someone who knows this person and who can at least kind of give you thumbs up or thumbs down if there's perhaps some other level of danger or bizarreness that's developing.
Yeah. And I think that's really important to address. I mean, often in a rural emergency department, it's you at work with maybe 2 nurses and maybe a tech who's helping and maybe a secretary, and we're really not equipped for if there's an explosion from a patient, explosive matter, where we can do the appropriate thing to protect ourselves first. So it's always important to be aware of that and recognize it early so that you can respond to that in as a safe way as possible, both for you, the staff, and for the patient. But avoiding those situations, I think, is paramount when you have even less staff, because you just don't have the numbers to watch your back, so to speak, and also protect yourselves in numbers. You know?
And if you think from a public health and safety standpoint, actually emerging psychosis with paranoia is much scarier than the flagrant sort of psychosis you might think of with a schizophrenia decompensation or manic psychosis or meth-induced psychosis, where people are so disorganized and agitated and discombobulated that they're going to end up in jail, or they're not going to go undiscovered for long. They're going to be directing traffic naked or just something. Whereas what's really scary, I think, safety and public health wise, is the person, often a man, who is quietly psychotic with emerging paranoia. And as all these dots are connecting, especially around work or family, he starts to think, okay, I need to take action. I need to do something. I need a weapon. I need to go take those people out at work who are part of this weird plot. I need to take out my family. And while there's only a small percentage of mass killers who are frankly not overtly paranoid, that definitely is a subset. And probably of the actual mentally ill folks who commit scary shootings and mass crimes, a very significant percentage of those are paranoid. And again, men, when they're scared, often lash out. Yeah. So if you imagine sort of the shut down, restricted affect, avoidant male in your emergency room, that your danger meter's going off and you think something is not right. There's, whether it's anger, suspiciousness. Again, people know this. You don't have to be a psychiatrist. If you've worked around enough patients, you know this person is not connecting to me in a normal way. There's some kind of deep fear, suspiciousness that should set the alarm bells going off so you can try to at least contact someone.
And then when you do have those alarm bells, do you treat them medically like you would treat the acutely agitated patient that comes in with like a meth psychosis, that you're just trying to calm them down and sort of make them sleep for a while and then they'll reset? Or how do you approach that? What would your recommendation be?
Yeah, I guess my thoughts would be, let's say you do reach some family member, or either a family member there in the ER or someone you can reach by phone. Path one would be the family says, yeah, he or she's acting strangely, but you're not seeing anything dangerous, just more like kind of quietly bizarre, psychotic. You might give a little psychoeducation to the family member to say, hey, if you were to see X, Y, and Z, these would be really concerning things. If you were to hear them talking about wanting to be dead, wanting to exact revenge, wanting a weapon, that would be an important time to contact either a mental health professional or even the police. If you are able to talk to family members and they say, oh yeah, there's actually some very concerning things going on, then I think you need to act. Then we're talking about 72-hour hold, as we have in Colorado, some sort of involuntary. I mean, that's tricky because, again, it's not a crime to be psychotic. At least in Colorado, you can't hold people against their will unless there's imminent risk of harm to others or self. But that's a tricky thing with psychosis. People are typically not opening up a lot about what their plans are. Again, that's why you need family collateral. And the vast majority of, at least in Colorado, of involuntary commitments, the data is coming from family. Yeah. Especially these sort of paranoid, quiet, planning some sort of violent revenge or action people. They're just not going to open up to you about that. That's the family that's going to give you info on that.
So the more the more insight you can, as a physician, gain about this patient's background or about this patient's illness, the better off you're going to be with the patient, the better off the patient's going to be as far as your approach to them.
Yeah. Well, it's almost like coming back to sort of the approach, much like, in the ER, you send people out the door with diabetes and hepatitis and COPD with some very bad illnesses. And you might tell them, hey, here's some things to think about with your COPD or your diabetes. And here's some follow-up options. But you often send people out that you think, ooh, I hope this goes okay. And I think, that's going to be true psychiatrically too. You very well might determine either from your own interview and or collateral input that someone is having psychotic symptoms or paranoia. And some of these people, you're going to discharge them out of the ER. Probably actually the vast majority of them, because most of them will not be holdable. So to have some contact with at least one family member where you could say, hey, here's some things to look out for. Your family member might remain sort of quietly delusional and paranoid, or this could escalate. The flames could start to burn and it could get scary, just to let them know of that risk. Another harm reduction thing that I do a lot is if I either determine that people have some paranoia or suspect it, I'll give a little psychoeducation, mostly about marijuana, because in Colorado with legal marijuana, there's this idea that I think pervades Colorado, because we have both medicinal, well, quote unquote, medicinal marijuana and recreational marijuana, that there's something therapeutic about marijuana, but we are realizing more and more that THC lights psychosis on fire. So if you have somebody with low grade kind of sparks of emerging paranoia and you put THC on that, look out. So a lot of what I'll do with my patients who are having sort of early stage or non-scary, non-hospitalizable psychosis or paranoia, I'm doing a lot of psychoeducation around, okay, let's talk about THC. Let's talk, if I think they have coke or meth issues, we'll talk about cocaine and methamphetamine. But the main thing is marijuana, because so many people in Colorado think that marijuana is medicine, including psychiatrically. But if there's something psychiatrically helpful about the marijuana plant, it's CBD, cannabidiol. But THC, for the most part, psychiatrically, just tends to light mania and psychosis and paranoia and agitation on fire.
So talking to them about that and sort of warning them off and warning them and talking to them about the reasons why is going to be a lot more helpful, although there's a good chance they'll be like,
no, I know.
Yeah.
I'm probably doing this more for myself than actually for them.
I'm already paranoid, and now you're trying to take away my THC. I don't think so.
Yeah. Well, you figure as in medicine, it's hard enough to help people. But when you have people sitting across from you who are deeply suspicious or even fearful of what you're saying and doing, that's a hard sell. And so again, really, I think what we're trying to do here is we're trying to ideally triage. Is there some way that we can figure out who is potentially a risk to themselves or someone else soon because of their symptoms? And again, occasionally you'll get someone who actually will open up and tell you, yeah, I'm actually thinking about doing something very bad because the voices in my head are telling me. I mean, I have that experience in my clinic, but that usually is because of a relationship built over time. In the ED, I think it's going to be, if you're going to find out something scary about them, it's probably going to be through family collateral.
That's good. That's a good point. How about, because this goes right to the heart of ED, like we need to identify the problem, then say, okay, this patient is going to go home or be admitted or in a 72-hour hold, so to speak. And then the third thing is, what do I do to treat that dopamine leak? Like where's that magic cork that I can slide into that leaking dopamine area that I can just pull off the shelf in the ED? And I don't know that there is any.
Yeah.
I don't know if that, what medicines or what medications might be helpful in sort of maybe keeping this from bursting into more of a florid type of psychosis.
Yeah. No, the home run outcome, which rarely happens, but occasionally happens in the ED, is you have a patient with psychotic symptoms. You're able to find out, oh, this patient actually does well on risperidone and had been on that until recently. And then maybe you even have some Risperdal Consta intramuscular in the ED, and you could give this person an injection and actually help them quite a bit with the time release. And it would also help because then there would be no compliance issue.
Right.
And I've actually had some of my patients end up in the ED, and I'm so impressed with the ED physicians that they did some research, figured out what antipsychotic they were supposed to be on, and gave them an injection. Wow. I think that's impressive. Far behind that would be finding out what they take and encouraging them to continue that, maybe giving them, here's some olanzapine 10 milligrams. We just happen to have some right now. We'll give you, and we're going to call in more. But again, as people get sicker and sicker psychiatrically, they're less and less likely to follow treatment, which is no more true than in psychotic processes. So, I mean, I spend an incredible amount of time and energy trying to get people in various stages of psychosis to take their dopamine blockers. I mean,
So it's not just the emergency department.
No, oh my gosh. Yeah, it's one of probably the top 10 skills that psychiatrists work on for years is how do you get people to take meds for conditions they think they don't have? Especially if
that's a good way to put it, because that's what you're dealing with. And I have those same conversations. But yeah, it's not like when they have high blood pressure and they're in for high blood pressure and they're worried about their high blood pressure. And they, as we've spoken to, they come in because they feel ill or they're worried they might be ill, where with psychiatric diagnosis, it's often the opposite of that.
Yeah. I mean, I have a number of patients who basically have a version of this story who have stabilized finally on some antipsychotic, and I will remind them during sessions, oh, isn't it great that you're taking medication X? And let's point out all the ways that you're better. And the person will say, well, that's true, but it still doesn't get to the fact that the reason that I have these problems is that I have a brain parasite. And you still have not addressed the brain parasite.
Mm-hmm. And yeah, and we have frequent flyers in the ED that come in and that is spot on. Like, they want to know why every doctor in the state has refused to treat their brain parasite, and that we're all in cahoots and know that she's coming early, so we put away the brain parasite medicine.
Yeah. I know, it's funny and sad, and it's as Treve, you and I were just talking about a few minutes ago. I mean, psychiatry is arguably the only field in medicine where the sicker you get, the less likely you are to either see that you're sick or want treatment or believe that treatment could possibly help.
So true.
Yeah. And I think, again, the ED, some percentage of patients you see are going to have either an overt or covert psychiatric process, which could be fatal to them or others. And it's busy and it's crowded in there. And if you could only remember one thing from this podcast, call some family member. Get someone else involved, because there's hopefully at least one person who has some history with this person. And again, that's not always possible, but at least putting a little effort in to see if you can, again, do what we call psychiatric imaging, which is family collateral.
Yeah. And, I think one of the things we can always ask is a lot, at least many places, and this is certainly not true of all rural EDs or all emergency departments that we're speaking to, but there's often some sort of support system where there's been a mental health worker, whether they're a counselor or a psychiatrist or a therapist, that may have a history with this patient. And if you can reach out to them, they may be able to provide some insight as well.
Yeah, I don't hear from emergency room folks very much, but I so greatly appreciate when I do.
Yeah.
And when one of my patients shows up and they happen to say, oh, I see Dr. Heacock, and that nurse practitioner, PA, or physician calls me, here's what I say: thank you. And usually I have a lot of insight to give them.
Yeah.
And my sense is that when emergency room folks have reached out to me, they're really grateful too. Usually our phone calls end, oh, wow, I should do this more often. Call the psychiatrist or call the mental health person, because typically these people who are ending up in the ER, I know them very well. And I know what makes them tick, and I know what their compliance issues are, and I know what meds are not going to work, and I know what you need to say to get them to take their meds, and I know what you should never say.
And that's invaluable.
Yeah.
Yeah. So
I was just thinking, I was running through my folks who are on maintenance antipsychotics. I would say it's a very small percentage, maybe less than 5% of my folks who struggle with psychosis who would tell you, even in their stable, healthier state, that they are taking antipsychotics to prevent psychosis. They would say things like, oh, I take these meds because I trust Heacock, but I don't think they work, or I take these for sleep, or I take these for my anxiety, or I take these for my depression, or I take these because my mom is making me.
Yeah.
But the level of insight that, oh, I take these to dial down my psychotic symptoms, that is rare indeed.
And I think that's important too. That's a great point, because oftentimes with these patients, that's one of those clues that you get. Like, you just happen to get the list of medications that they're supposed to be on from the local pharmacy, and you see, Risperdal. Mm-hmm. And you ask, well, why do you take that? And they say, because my mom makes me, or because, but it should be a clue to you.
Yeah.
And just like reaching out to the family or reaching out to the care providers, looking for those clues, looking for those tells. And then, as you mentioned, Craig, with the history, when things aren't adding up, and this hits home for me, because I know I've had those patients where you say, that's a lot of glitter for 8 a.m. And you think, but the rest of this conversation's pretty normal, mainly because you haven't asked the right questions,
Mm-hmm.
or you haven't touched on the right things, because they're in for something like a sprained ankle, or maybe they injured themselves accidentally, or maybe they were lost and they were brought in because somebody was worried about them and they had some exposure and it was cold out, but they seem okay. Mm-hmm. And so looking for all those tells, I think, is so important. And oftentimes it's after they've left, when you're putting it all together and it's not adding up, that you just think, that person might have been psychotic.
Yeah. I mean, one thing I wanted to mention about psychosis earlier, which might be helpful, is psychosis is not a continuum like 0 to 100 or the dial 0 to 10. I mean, psychosis is better thought of as a number of dials of potential symptoms. So maybe you have auditory hallucinations 0 to 10. You have paranoia 0 to 10. You have poverty of thought. You have ideas of reference, which is where you see special signs to you in your life or in the community. Mind reading, delusions of grandeur. I mean, there are probably 10 or 12 common psychotic symptoms. And sometimes people just have one of those. I saw a guy the other day, one of my longtime patients with schizoaffective disorder, and he looked good. He sat down, he said, my mood's pretty good, and I'm sleeping well, doing his job. And then about 20 minutes in the appointment, he started to cry. He said, I don't want to hurt anybody. And I said, what? He said, the voice has been telling me that I need to do this thing. And so then he went on to describe this really awful sort of assault that this voice was telling him to do. But he had enough insight to realize, I don't want to do that. I should tell my doc. He was actually functioning well. And so this is not an uncommon thing with psychosis, that you can have just 1 or 2 dials turned up and someone actually looks okay. I mean, I think in retrospect, like this guy, something was off even when he first sat down and told me things were going well. But again, if you can think of psychosis as a number of potential symptoms, which can be at different intensities, rather than someone is, somewhere on this, 0 to 100 dial of psychosis, because I think that's not accurate.
Yeah. And I think that's an invaluable point. When you look at the ED literature, if we do a literature search for psychosis in the emergency department, you put those words together, what you're going to find is acute agitation, acutely psychotic or combination of those words, and then the treatment for them, which is going to include Haldol, benzodiazepines, those types of, but that's where we kind of, in the emergency department, that's where we stop with psychosis.
Yeah.
And we're doing a disservice. I mean, certainly those patients, we need to protect ourselves and protect others and protect them. And there's a lot of value to using the appropriate medications in the appropriate time. But with these patients, this is a whole group of patients I feel that we could do a better job with.
Yeah.
So that's why this is, that's a very valuable insight for us as physicians. So,
I mean, a lot of ways psychiatry has a serious vocabulary problem, if you will, because we talk about depression. I mean, everybody has an idea of what depression is, but we use it in a very specific way in psychiatry. Or psychosis, I think even physicians have differing ideas as you said, when you do a literature search, whereas a more helpful literature search might be already breaking down like paranoia or auditory hallucinations or delusions of grandeur or thought blocking. Again, there's a number of features of psychosis, some of which are just more painful to the person, him or herself, and others are more risky to their well-being and that of others. One of the most scary, besides paranoia and fear, would be command auditory hallucinations. And those, it's interesting when you ask about those, if you can build a little bit of trust, a surprising amount of the time, especially if you say, we often see people with depression or on these meds who hear voices telling them to do things. That's a common thing. Like, do you ever experience that? A surprising number of people will actually bite on that and say, oh yeah, I have that. It's been a few weeks, or just give you a shocked look and say nothing.
Like, how did you know?
Yeah. How did you know? So
to put it in the perspective that's emergency medicine, I've had, in emergency medicine, a lot of people feel that there's 3 diagnoses for psychiatric illness. That's normal, crazy, or freaking crazy. Yeah. And if they're the 2 or 3, we need to do something. Mm-hmm. But that tells you, it's more of a very blunt tool, and we can do better.
Yeah. Whereas, another or an alternative way to think about it is there something we can do to help this patient with psychiatric symptoms now? Do we need to take action now, or do we need to maybe let family know, again, a little psychoeducation, what might be happening? Because there are actually some very concrete things that ER staff and docs can do. And for those of you who haven't heard the suicide podcast, you should go back and listen to that, I think. But it can be frustrating and overwhelming to deal with a lot of these folks. But just some very simple things, trying to get family involved, trying to, again, ask yourself, instead of, is this person moderately crazy or totally crazy? Is this person needs some kind of intervention right now? Yeah. And, oftentimes no, but at least when you go down that road of asking, okay, is there any intervention that needs to happen now? No, but it's very conceivable that this person could get to a point where they need that, and then giving the patient and or family some resources or thoughts about when they might need to act. Again, and oftentimes that's going to be family, because as people get sicker in their psychiatric illness, they often are unwilling and or unable to seek the treatment they need.
Well, thank you, Craig. Once again, Dr. Heacock, this has been invaluable, and I hopefully we can use this and apply it to our environment in the emergency department. Certainly, if anybody has any questions or any thoughts, please feel free to email us at ruralem.org. And greatly appreciated, Dr. Heacock.
Good to be here.
And we look forward to doing it again.
Me too.
This concludes the interview between Craig and Treve. I hope you enjoyed the discussion on recognizing psychosis in the emergency department. When they told me what they were going to do the interview on, I was expecting a discussion on the agitated, delirious patient, but this opened my eyes, as psychosis is much more than this. So thank you, Treve. Thank you, Craig. Before we close, Treve and I both wanted to stress a few points. The first point, number one, family collateral is the imaging of psychiatry. Craig has said this more than once, and I have changed my practice because of this. It is surprising at how much more information I get when I talk to family and how it can change my management. So thank you for stressing that again. Family collateral is the imaging of psychiatry.
I felt a little validated and a little released when he talked about that, because often we worry about the protection of the patient or the HIPAA.
Correct.
And since we had that discussion, I'm right with you. I feel the same way. I think it really changed how I approach these patients. And I think it also helped in my approach with empathy with these patients. I can't say directly, but indirectly, I think it really has.
Please get that collateral history from family and friends when you have a mental health patient. Treve, what's the second thing we wanted to share?
We also talked about the use of marijuana.
No, we don't have very much marijuana here in Colorado, right, Treve?
And you may have noticed in the podcast, we had a fit of giggles when we started talking about it. And it was not because we were eating hash brownies. It was because it is so pervasive, and we have so many conversations with our patients where they say, no, this was medically prescribed.
It's for my glaucoma.
Yes. And so we just shake our head and smile. But Craig made a really good point, and he broke it down between the THC and CBD. And we're not in that conversation today to go into depth regarding THC and CBD. But THC, he did talk about how that is it lights psychosis on fire. It increases mania. It increases psychosis. And he said they've really seen a lot of research that's shown that it is a directly can cause increase of those symptoms. And so that's something to be definitely aware of with the patients that are coming in and using marijuana products or THC products. That's a good question to ask or research.
And a good topic to discuss with them. And sadly, there is a lack of insight. They think the THC is helping.
Yes.
And it's the same with the hyperemesis cannabinoid syndrome.
Yes.
They think it's helping, and they won't. It's very hard to convince them that it's actually making things worse.
Yeah. And they're sure, because you're a person of authority, that you're trying to take away their free choice of, hey man, I'm using this medicine and it's helpful. And that's, that's why we had a chuckle about it when we were discussing it.
So the next point is number 3, call the mental health provider. This can be the patient's psychiatrist, counselor, social worker, etc. I have done this in the past, and it has made a huge difference. These psychiatrists know their patient well. They know how they can help the patient be more cooperative. I've even given the phone to the patient so they can talk with the psychiatrist to convince them to take the medications and to cooperate. So please call the mental health provider.
And I think they will. I think they do appreciate it. And even if they're not available right at that moment, I am willing to bet that they will call you back fairly quickly. I've had positive experiences as well.
The last point I wanted to make, number 4, is that psychosis is not a single continuum, but a number of potential symptoms of different intensity. These symptoms can be auditory hallucinations, command hallucinations, paranoia, poverty of thought, ideas of reference, mind reading, delusions of grandeur, and many other symptoms. Patients can have just one of these, or they can have many of these symptoms, and each at varying intensities. Before we recorded this summary, Treve shared with me a visual that he had, and I'd like him to share that visual. Could you do that, Treve?
Yeah, and so I would say one of whether we were talking about bronchiolitis a month ago or a couple of months ago, or talking about psychosis, one of the great things about doing these podcasts is I walk away or leave these podcasts, and I almost always have learned something profound or something amazing that really makes me a better physician or have a better understanding. And our last little discussion with Craig regarding psychosis, when he sort of painted the picture of what psychosis is, it's not a symptom on a continuum. He talked about it as having it's not just one diagnosis. It's multiple symptoms of different intensities. And as he was describing it, what I thought about is sort of an analog soundboard, like when you're recording music. And I thought,
or a podcast,
yeah. So the Beatles are well known to have put some amazing albums out there using only a 4-track recorder or a 4-track, which I find amazing. Considering what their body of music is. So when Craig was describing this, I had that picture in my mind. And as he was describing the symptoms, I was adding channels. And he talked about 8 to 10 different symptoms. And it's certainly not inclusive, but I had this little soundboard in my mind where he had auditory hallucinations, paranoia, thought blocking, poverty of thought, mind reading, delusions of grandeur, command hallucinations, idea reference. And all of those are separate entities, and any individual patient can have certain degrees or intensities of any or all of those. And that's why the idea of psychosis is it can present in a lot of subtle and different presentations. I think all of them, when you're talking to those patients, there's something at the back of your mind where you're saying, okay, this is not really, this person is not connecting on all circuits here, but they're not the same as the last person I saw with psychosis. And that was profound to me. I immediately was flashing back to several patients that I had seen in the past, and I was like, this solves the problem of why I couldn't put it together or why I couldn't call it when I thought it was psychosis. And so when you're listening to it, go back, listen to it again, think of it as that soundboard and being able to modify all of those different symptoms. And it really makes sense. And I think it really helps when you're evaluating and talking to these patients.
Thank you for that visual. I think that helps me. It helps our listeners understand a little better of what psychosis is. It's more than just hallucinations. It's more than just paranoia. It is a disconnect of reality, and there are many symptoms that can be manifest with psychosis, and these symptoms can all be at varying intensities. So thank you, Treve. Thank you, Craig, for this discussion. I hope our listeners enjoyed it. Do you have anything else to add, Treve, before we close?
Hey, thanks to the listeners. You guys knowing that people are listening and we getting the feedback just really helps us keep the fire burning, and we really enjoy doing this.
I agree, Treve. Well said. Listeners, thank you for doing what you do, and thank you for listening to our podcast. Share this with your friends. Share this with your colleagues. As the more listeners we have, the more content we will be able to provide. And one last exciting announcement. We are going to be starting a YouTube channel. We will include every podcast that we have made. I am in the process of making PowerPoint presentations for each of these podcasts so you can have visuals. If you are a visual learner and want to have something on the screen to watch, please get onto YouTube. Find us by searching for Rural EM, and you can find our episodes. Please subscribe to the channel. That will really help us. And also, we want to include procedure videos that will help you learn or understand what we are talking about. So check us out on YouTube. We will get that up hopefully within the next few days or next few weeks. So keep an eye out for that. And in closing, once again, thank you for being an emergency provider in a small community or a rural community. You really are an everyday hero.